So it sounds like the preference would be cystectomy, and totally agree with that. Now, what if the patient's unwilling or unfit to receive a cystectomy? What's your next kind of go-to option here?
Yeah, for us, with these recurrent T1 high grades after BCG, unwilling or unfit for a cystectomy, this is where you're looking at other alternative options now. So if they're meeting the criteria here for BCG unresponsive disease, you have a couple of different options. Our current preference at this point is the utilization of gemcitabine and docetaxel intravesically, but FDA approval currently is just for Val Rubicon and pembrolizumab.
Yeah, I mean, comprehensively, the way I kind of think about it is we have cystectomy, we have pembro, we've got gemdosi, we've got, of course, clinical trials. Val Rubicon is an FDA-approved agent that I don't even really kind of bring into the conversation. Then there's the stuff that's kind of coming through the pipelines that I think is exciting. So again, cystectomy or second induction course of BCG would be, and of those, and this is an opinion, in this patient with large volume recurrent T1 high grade, while I am generally a fan of gemdosi, to me, I'm not super keen on another intravesical option necessarily if they've got a lot of, early recurrent tumor. And I would actually maybe lean towards pembro, but I'm curious to see what you all think.
So if we're talking about our like super high risk, very high risk T1 patient here, I think another potential option, because this is a patient we're concerned that may have clinical understaging. So I would completely agree that I would be uncomfortable with an intravesical option in this. Although it's only been published in abstract form at this point, there is the chemo-radiation potential option for some of these patients. And I do discuss that for patients that I feel that they probably do have muscle invasive disease, even though clinically they're T1. And I sort of counsel them as such. So the NRG data is abstract form. Honestly, it's not that I'm not super enthusiastic about it, but I think, there's robust data from muscle invasive disease. So whether your early T1 post BCG would behave differently, I think is a little bit unknown. But I do think that that's an option for these very high risk T1 patients for sure. For your sort of run of the mill high grade T1 with BCG unresponsive disease without, significant multiple risk factors, at least my belief is that we should be supporting clinical trials first. And for these high-grade T1 patients, I do think that adding that systemic component that you had mentioned, pembrolizumab, but the Keynote-057 data certainly wasn't anything to write home about. So I like these ideas for the clinical trials that are combining immune checkpoint inhibitor with an intravesical agent. The Alliance trial that's pembrolizumab plus intravesical gemcitabine, for example. And so for high-grade T1 patients, I tend to preferentially recommend that clinical trial or clinical trials like that with a systemic component, where for patients that may just have CIS or high-grade TA, BCG unresponsive disease, those may be patients that are better served with a intravesical only treatment option and avoiding the potential, immune-related adverse events with an immune checkpoint inhibitor.
Yeah, thanks, Eugene. That's an excellent point. I mean, I think for a variety of reasons, sometimes chemo-radiation doesn't come up. I mean, case in point, I didn't even mention it, but I think you're absolutely spot on. And while it's not a home run, and many of these patients are probably going to have fairly significant lower urinary tract symptoms, it may not be the best option, but point well taken. And I think, this really kind of digs into when you look into somebody's bladder, you either something goes off that says I'm worried or I'm not worried. And when you're worried, it kind of is like cystectomy, systemic therapy. And when you're not worried, you feel like you could try something, gemcitabine, docetaxel, and you're not going to, miss an opportunity of a window for cure.